So, good morning, all. Good morning, and welcome to our patient safety second patient safety diagnostic safety webinar. Thank you for joining us today for our online session. The title of the session will be Diagnostic Safety Across the Spectrum. So, myself, Keshav Singh, representing Patient Academy for Innovation and Research. We are a patient advocacy organization, and patient safety is one of our core focus. So over the past 3 years, we have been working on World Patient Safety Day. This year, we have started a six series of webinar focusing on understanding diagnostic safety. So we have already done with the first webinar, which is in the previous month, and this is the second webinar of the series. I would like to introduce Dr. Ratna Devi, and can we have the slide, please? Yeah. So Dr. Ratna Devi is a medical graduate with a master in business administration and has a deep passion about the health system strengthening, especially with the patient and correlation and code production. She has over 31 year of experience in program management, strategy and policy development, healthcare system strengthening and advocacy. Dr. Ratna is passionate about patient empowerment and inclusion and work in the India as well as globally to drive the agenda as a past chair of the Indian Alliance of Patient Organization, IPO, and founding member of APARDO and CEO of Dakshama Health and Director of Patient Academy for Innovation and Research. So Dr. Ratna will be, setting the context. Over to you, Dr. Ratna. Hope it, yeah.
Thank you, Keshav, and thank you for that kind introduction. So as Keshav said, we are a patient advocacy group and we work not only in India but also in the Asia Pacific region. Our initiative is called Patient for Patient Safety Network Asia Pacific, and we have 8 board members from 8 different countries, but we represent the entire Asia Pacific region through various patient organizations who are our members. The India initiative is called the Patient for Patient Safety Network India. We work very closely with World Health Organization on patient safety initiatives, not only globally and in the region, but also in India. And as Keshav rightly pointed out, this is one of our flagship programs. Our aim to work on this and increase awareness amongst patients, caregivers, as well as community around patient safety is to help them make aware about their journeys and to understand what kind of trigger points exist where there could be harm to patients, and also be able to contribute to the system so that any vigilance measures, for example, material vigilance or pharmacovigilance measures, can receive contributions from the patients as well. So I've spoken at different forums regarding why patient voice is important, and most data is usually collected through the formal systems, which is the hospitals or the manufacturers. However, the incidents happen with the patients, and with healthcare moving out of institutional structures, a lot of harm can happen outside of a hospital or a healthcare institution, which may not be recorded because the patients are not aware that it should be reported. So, how do we build capacities of patients and caregivers so that they understand what harm is? And how do we then report it back to the system so that healthcare becomes safer for everyone? This is the objective with which this initiative was started around 3 years back. And as Keshav said, we've had series of webinars. We also engage patients in other activities, patients and patient groups in other activities where they sit down and participate in, say, poster competitions or essay contests, where they understand what patient safety is and represent it in their own language. As an institution, we have participated in several international forums as well as national forums, bringing the voice of the patient to different areas. So that is a brief introduction of the work we do, and I'm very grateful to the 4 speakers who have agreed to join us today to bring their perspectives on diagnostic safety. Again, as diagnostic safety, it's a very complicated area because of the spectrum that it covers and not often discussed in various forums. So this is something that we have tried to bring together to be able to not only empower patients and their caregivers, but also healthcare providers to understand what diagnostic safety is and why they should be aware of the various aspects of diagnostic safety. So, with that, I will hand over to Keshav to introduce our speakers. I believe Dr. Shivkumar is held in a procedure and will join us a little later. So, we will be changing the order in which the speakers are invited. Back to you, Keshav, and thank you so much.
Thank you so much, Dr. Ratna, for setting the context for us to deliver the whole webinar. So it's my honor to as you can see, we have an exciting lineup of speakers who will be sharing their expertise on various aspects of diagnostic safety. We will cover topics like pathology and histopathology to clinical diagnostic procedures, radiological and radio imaging, and then point of care testing. So it's my honor to invite and welcome Mr. Anand K. Anand is a managing director and CEO of Agilus Diagnostic. He is currently the co-chair of the Northern Region chapter of Net Health and co-chair of CII's and Delhi State Committee on Healthcare and Wellness. Recently, he won the Healthcare Leader of the Year award at Altus Healthcare Summit 2023, Dubai, and was facilitated as a Diagnostic Leader of the Year at VOS Diagnostic Summit 2024. Very warm welcome to Mr. Anand. Thank you for joining us. Then I would like to introduce Dr. T. Shivakumar. He is an honorary secretary, IAGES, Indian Association of Gastrointestinal and Endosurgeons, and he is advanced laparoscopic and robotic surgeon at Shiva Hospital, Kanyakumari, and he is the chairman of Shiva Hospital, Kanyakumari. Also a course director at Shiva Institute of Minimal Access Surgery. Sir will join in a while as he is in a surgery. So can we shift it to next slide, please? So I'll be honored to welcome Mr. Kabir Mahajan. Kabir is currently Associate Director of Mahajan Imaging and Lab and is leading business expansion and surgery. Previously, he was the Chief Secretary Officer at Quellibin, a global radiology and oncology artificial intelligence startup based on the Valencia, Spain, where he is leading growth and strategic partnership. Kabir is an MBA from IESE Business School, Barcelona, Spain, and BCom honors graduate from Shri Ram College of Commerce, Delhi University. We are a pleasure to have you here, Kabir. Thank you for coming. Thank you for joining our webinar. And then we would like to introduce Dr. Anu George. Dr. Anu George is a pathologist over 30 years of experience. And she has been working on strengthening and quality improvement of public health labs of several years. She has lead two CDC for the same, and currently she is working as a project of the Global Fund on Infection Prevention and Control in the TB sector. We are glad to hear you, ma'am. For the further process of the webinar, I would like to welcome on stage Mr. Anand. So can we have Mr. Anand's slide, please?
Sir, would you like to present on your own? And I think you have the share
Yeah,
screen option.
I will share. I will share on my own. Thank you.
Sure,
Thank
sir.
you so much. Are you able to see my screen?
It's just coming up. Yeah, we can see it now.
Right. Good morning, everyone, and thank you for this opportunity. Can you hear me?
We
Yes.
can hear you. And if you could make it full screen, then perhaps we can see the slides as well. We can hear you. Please continue.
I think the Zoom just quit by itself. Yeah,
No problem. We can see you now. So if you could share once again, because the slides have disappeared.
right. Can you see my screen now?
It is coming,
It's
sir.
just coming up. It's coming up. Yeah, we can see it now. It needs to be made full screen.
No, I think there is a problem. I
Shall
think
we try sharing?
whenever I try to start, so I will do a stop share now
Okay, Vikas, if you can share the slides.
because
Yeah, your slides are up, Mr. Anand.
I think there is a network issue with Mr. Anand, can you hear us?
His frame is frozen, I think. Yeah, can you see the slides now? We
disconnected.
can't hear you. Oh, yeah. Okay, we can hear you now.
I'm sorry, I got disconnected once again. So I think this is
No,
some.
no problem. I think your slides are up. If you could just go ahead.
Right. Thank you. Good morning, and thanks for the opportunity, Dr. Ratna, and thank you for the kind introduction. So, in fact, since we have very little time, I'll just wanted to cover a few aspects. And this is regarding the patient safety when we talk about diagnostics. So, one of the key aspects that we know, all know about patient safety in diagnostics is that diagnostics test results, especially the lab reports, they affect about 70% of the clinical decisions. So, in that case, it's very important for us to know that the results are accurate and results are right. And that's the reason diagnostic safety is a very important concept in patient safety. Can you move on to the next slide, please? So, since I'm the first speaker, so probably I'll just touch upon what patient safety is. And patient safety is basically avoiding harm, minimizing the avoidable harm that is there in the patient interaction with the healthcare system. So, the timely and accurate diagnosis is the foundation to good clinical practice, and key to establishing trust is through the accuracy and reliability of reports coupled with timely delivery. So, these are the key aspects of patient safety as far as diagnostics is concerned. As 70% of the clinical decisions are based on laboratory reports. So building of trust both between the patient as well as the doctor and the laboratory is the circle of these three people is very important for ensuring patient safety. Next slide, please. So one of the key aspects that we see in the Indian context is that in India we have a very large number of laboratories. So it's an extremely fragmented ecosystem as far as diagnostic laboratories are concerned, and we have about 17% of our industry in the so-called organized sector, and more than about 70 to 80% are in the unorganized sector. So there are various norms, and since health is a concurrent subject, it's covered both by state as well as sector. The rules, requirements, are all very varied across the platform. So what we also see is that something like an accreditation, whether it's an NABL, ISO 15189 kind of accreditation, is also It's not mandatory; it's voluntary. So people can choose to be that, and it's not really fully enforced. And when we talk about clinical lab establishments, which come under the Clinical Establishment Act, which is important, where there also we find difference in terms of implementation between states. So this actually creates a platform where patients have access to services, but these services, the quality of these services, as well as the reliability of these services, and how they affect patient safety is not very clear for the patients themselves. Another important aspect here that we'll cover, I'll take it in the next slide. Next slide, please. So when we talk about accreditation, that's one of the testament of to trust. So it's important. Today we have about close to about 300,000 labs, 3 lakh labs across the country. But when you see number of accredited labs, we have around 3,000 labs. So that we can see that the number of labs which are accredited, even in that, the most common accreditation that's being taken up is the NABL, which is more of a where you can choose certain tests. Like there are laboratories which can call themselves accredited, but only a few tests will be accredited. The rest of the tests will not be accredited. So it's not an all or nine none kind of a concept. So those kind of aspects also affect patient safety, in the sense that you think that there's a lab which is NABL accredited, but you don't know about the scope of the tests which are covered in that accreditation. So another accreditation which is there is also called the College of American Pathologists, a CAP, which is an all or none kind of a model, where the entire laboratory, not only the testing but also the overall scope of testing, and the various parameters which are being used, the kind of people that are being hired and employed for these testing services are also covered in that. Next slide, please. So the anatomy of errors in healthcare, if you want to look at, there are three main factors: the organizational factors, the environmental factors, and the human factors. So here, if you see, the human factors is one of the most critical aspects in healthcare, where you have clinical competency, communication skills, and problem solving. And on the top, you have the organizational factors, like what is the culture of the organization, what is the purpose. So whether we are going to be driven by profit or driven by purpose. So that and how do you actually balance both the aspects of profit and purpose, and create a responsible and sustainable kind of a culture in the organization, where policies, procedures, and regulations are followed in the right way. And then you also have the environmental factors, like what kind of equipment that you have, what kind of resources you have, and the constraints. Next slide, please. So this is just to talk about the organizational culture which drives the patient safety. It can be the worst case scenario of a pathological culture, where there's no care about anything that happens there, as long as nobody is getting caught. To the highest end, where you have the predictive kind of a model, where this is how we need to do business here. So this is what we are dealing with patients. There is empathy, and behind every sample there is a patient, and every patient is an emotion, and behind every patient there is a family which is standing behind that patient, and that is the whole thing about that particular sample. So this kind of a empathetic approach should also be driven as in the organization. So the rest of the things, like the leadership safety, and how key is safety as far as people are concerned in the laboratory. So those kind of aspects are also part of the way in which we can increase trust and accountability within the organization. Next slide, please. So I'll not take too much time on this. This is just a bit more detail. Go to the next slide, please. So what exactly is the kind of culture of patient safety that we can create in organizations, especially in laboratories? Is about having an informed culture, a culture of openness, a just culture, and a flexibility, and a learning culture. So this is a continuous process, because as we know, in the medical science advances much fast, and you also have diagnostic procedures which also continuously keep upgrading themselves. So the technological obsolescence, especially in pathology, radiology, and related subjects of diagnostics, is very high, and where you have new things that come up, and it's very important for people to understand the patients to understand that what they get and how do we work with that particular report and where to do and what to do with those reports. So those kind of information sharing is very important in the organization perspective as well as from the patient's perspective. Next slide, please. So another important aspect is the health data protection. So as we all know, we are now in the cusp of implementation of the DPDP Act, which talks about data privacy and protection for the patients. So we have the National Digital Health Mission, the Ayushman Bharat Digital Mission, ABDM, which have also brought about this ABA IDs, by which you're able to create systems where the data can be shared with patient consent. So patient consent is very important, and that knowledge and awareness for the patients is also very important when they are sharing data about their lab tests, how it is going to be used by the organizations which share the data, and how it is being used for their benefit or to their loss. So these kind of things patients should be made aware of that. And it's also important for the patients to know whether the organizations with which they are working in terms of their healthcare, whether they follow the best practices in terms of data security, in terms of network management. So make sure that the data which is being shared in trust, in confidence with the healthcare organizations is not being misused, or it can be stolen by somebody else. Next slide, please. So in the laboratory, the most important thing here is that the errors occur more in the pre-analytical, analytical, and post-analytical phases. So we need to understand how do these errors actually affect the whole overall safety of the patient, and whether it is starting from an inappropriate test being ordered because the doctor is not aware of what exactly is the right test to choose because of the plethora of tests that we have today. And also in terms of how the tests are being done in terms of analytical variables, analytical procedures, and then post-analytical, how that gets interpreted. In India, we also have the peculiar situation where, the reports are handed over directly to the patients. Large reports, volumes of reports are handed over to the patient. Whereas in some other countries like US or the Europe, you find that the reports are not handed over to the patient. The reports go directly to the doctors because these reports are meant to be interpreted and analyzed only by qualified medical professionals. But unfortunately, in our country, so we have patients have direct access to reports on the first hand. So they try to interpret those reports, and it's important that the reports don't get read individually because they need to be clinically correlated. They need to be correlated with the radiological findings. They need to be also correlated with the other tests that they have done. So instead of that, any particular value is taken in isolation, and patients either have panic reactions or anxiety based on some reports, or they also have a false sense of wellness by seeing some reports. So how do we actually avoid this? Is also something which we have to create in terms of awareness in terms of how the patients will look at it. And the most important aspect in the lab, what we see is that pre-analytical errors. So how do we identify? Today, we don't create any identity for the patient. So the patient comes in, they say that this is their name, and we take the sample. So in very important cases where there are medico-legal implications, where we try to create a sample trail of patient identity. But in most of the cases, we assume that the sample belongs to the patient. So the most of the identity related parameters that we look at is in terms of how the sample is being labeled, it's being barcoded, and then the whole chain of custody in terms of how the sample comes into the lab for processing. And whenever there is the tube is being aliquoted, the sample gets aliquoted, how do you make sure that the same sample labeling goes into that as well? And all these aspects are very critical when it comes to pre-analytical phase, where you rightly identify the patient, and the correct report of the patient goes back to the patient. So this aspect is not clearly understood by the patient. So it's very important that the labs are cognizant of this, and they make all efforts to ensure that this happens. On the post-analytical side, also, we have these issues of, what is the impact on the final outcome of the patient if the doctor doesn't understand the purpose of the test, or if the doctor is also not aware of, the variables that affect this particular result, because of the patient's diet, or whatever drugs they're taking, or whatever, the nature of sample collection, how it has been taken and how it has been stored. All this could affect the values, and this could lead to wrong information being shared with the doctor. And the doctor, if he's not cognizant of these aspects, they may lead to wrong treatment being given to the patient. So those kind of aspects are the post-analytical kind of aspects. So we have these three large groups which probably patients don't understand, but which they need to be aware, where the laboratory affects the patient safety. And it's also important for the lab personnel to understand the critical role that they play in the overall management of the disease, as well as prognosis of the patient, by the reports that they give to the doctors and the patients. Next slide, please. So just an important way to talk about this is how do we actually bring about the errors. That we talk about more about errors. We keep expecting those errors and inspecting and then correcting the errors. So that's the major aspect here. So we should never be overconfident on errors, and the expecting that errors will never happen is a very wrong way to look at it. So we need to any total quality management program that we have, we should look at how do we prevent the adverse course of events, and how do we actually make sure that we have a proper preventive action and corrective action in place for all the errors that we can talk about in the laboratory. Next slide, please. So this is just an overall perspective. I'll not cover details on this. Next slide, please. So the various accreditations that most of the major labs can have, and which we also have as Agilus Diagnostics, we have the College of American Pathologists accreditations, the National Accreditation Board for Laboratories, which is the NABL, which is ISO 15189, and we also have the NABH, which is for radiology centers. We also have the RNTCP program accreditation, which is for the tuberculosis, and the ISO 9001 and ISO 27001 for IT systems and the R&D systems. So these are all various aspects, and also compliance standards. So you have the ISO compliance standards with 15189. You have the clinical pathology accreditation standards. Then you have the CLIA regulations, the CLSI regulations, and you have the Clinical Establishment Act and the various acts which are there in place by the government of India, and also the accreditation by DSIR when you're doing some research kind of activity. So these are some of the certifications that we can look out for in the organizations that we plan to work with in terms of healthcare and laboratory services. Next slide, please. So on the closing note, I'd like to say that one of the key aspects we need to understand is that we are a highly unregulated industry with no clear minimum standards, and the need for in-depth policy making is essential for laboratories. And the patient safety in diagnostics is very paramount, since it's the first point of contact and the starting point of any healthcare journey for the patient. And organizational culture is also one of the key aspects that drives patient safety, and especially in a laboratory, that's very important. How they understand the sample as a patient, and the communication, not only with the doctors but also with the patient. How do we engage and communicate with the patient on the aspects of safety, and how the lab reports will affect their health is something which is very important. We need to do both communication to the doctors as well as to the patients. And establishing a culture of safety within the healthcare organization is also a very critical aspect. And patient confidentiality of reports is also going to be very, very important. And we need to make sure that we don't share reports, very, very carelessly to different people. And upholding ethical standards that promotes patient trust and safety is also very important thing that needs to be cultivated within the organization. The progress in patient safety directly corresponds to the health of our society, and diagnostics as a key part of healthcare has an enormous role in shaping this journey. Next slide, please. That's it. Thank you. I think I'm not. I hope I have not taken more time.
No, thank you so much. And that was quite comprehensive. I think we can have one exclusive 1 hour webinar just speaking on this topic because there are so many issues that you covered. I just wanted to ask a couple of questions before we move to our next speaker. You laid a lot of stress on trust, and so from the patient perspective, when they report to a lab based on a prescription, they do not suspect anything. They trust that the lab will give them a report which is useful for the physician to diagnose whatever ailment they have. So, as a man on the street, if I were to understand which lab I should go to so that I can give accurate results to my physician, how would I look for that information? You did talk about accreditation, but is it publicly available information? Can I check somewhere to know whether a particular lab is accredited or not?
Yes, I think that's a very important aspect. Patient awareness on this aspect of quality is very important. Post COVID, we have seen also a lot of change in the patient behavior, where patients have been exposed to, enable accreditation because of the COVID requirements for enable accredited tests. So otherwise, and also when they go to the neighborhood laboratories, what they found was during those COVID period where the aspect of safety was very critical, so they found that unhygienic conditions and all that, where they're able to, where they're seeing the laboratory being doing things. So they had some suspicion on that. So the patients had moved on from there and looking at new things. So like you rightly pointed out, accreditation is one of the first aspects that we can look for, and it is available publicly. So you can Google out and see whether the particular lab that you're going to is accredited, and also whether the center that you're going to is having all the facilities. Mostly, we still have a lot of recommendation coming from doctors. So we have about 60% prescriptions being driven by doctors. So what happens is the doctors definitely tell them that they go to these labs, they'll get better reports. But at the same time, for the patient also to make sure that these labs will give them good reports. They can look at the reviews, they can look at the websites of the labs to see whether their accreditation standards are being met. So those are the aspects that you can do.
Thank you. And you also talked about pre-analytical, analytical, post-analytical. I think prep of the patient is very important for pre-analytical, especially when you're doing, say, a fasting blood sugar or a prothrombin time or a bleeding clotting time. And very often, even though the physician has advised the patient to go nil orally or stop medications, they forget or the history is not taken before the sample is collected. So, what would be your message to patients and patient groups and the people in general about following such instructions and also advising before the sample is taken to the person who's taking the sample?
So this is a very, very important aspect, especially the patient history. So many times, what we get in the lab is just a sample. So we have no
Yes,
idea about the patient's clinical history or the standing. And on top of that, we also don't know what drugs they are taking.
exactly.
Whether they have been given the proper instructions in terms of what they should do to cover. So many times, the labs. At the point of contact of taking the sample, don't inform always the patient about these aspects. So I think that education, especially from the lab professionals, it's very important that whenever they try to when they see a patient coming for a test, so they cover all these aspects in a checklist kind of a model where they're able to take information from them in terms of what drugs they have taken, whether they're really fasting or not, when was the last meal, and also if they've collected a sample like a urine sample, did they really go through the proper process? Sometimes you require midstream urine, you try to avoid skin contamination. So all those aspects are sometimes not missed out, largely missed
Yeah.
out. And you get into issues of, later in terms of when it comes to how you really interpret those reports. So I think that information, we can't expect the patient to know everything.
Yeah.
It's very important that the labs also set out a sort of a protocol by which they have a checklist which they can clear before they take the sample from the patient.
Thank you so much, Mr. Anand. I had one more question, but in the interest of time, I will put it in the chat box. And it is related to our hub and spoke model these days, where we have collection centers who report to homes and then collect the samples, where quality is difficult to assure. So, some words of advice on that, and if you could come back to us, and I will hand over the floor to Keshav now for inviting our next speaker.
So thank you.
Thank you. Thank you so much.
Thank you so much, Mr. Anand, for giving the beautiful presentation. So I would like to introduce our next speaker on the panel. Dr. T. Shiva Kumar is Honorary Secretary of IAGES. Very warm welcome to you, Dr. T. Shiva Kumar, and we are we are happy to listen from you the whole perspective.
It's my
So,
privilege. First time I'm sitting in such a platform. When I think so, Keshav and Dr. Ratnadevi was calling me. Really, I was a little bit reluctant to come in, but as it's really, yeah, I'm not joking. But it's going to help the technician and patients and thing like the sentimentally Dr. Ratnath pulled me in. I think so. No problem. Even I don't know what to prepare for because basically I'm a laparoscopic surgeon and endoscopist and robotic surgeon. So maybe Mr. Anand covered nicely whatever the safety precautions on the even not only on the lab side, he was covering on the most of the medical side also. He was covering. Just I'm going on listening on the last part. So I think so. I'll even though I prepared some my assistants are preparing some slides. I told them to prepare I put that forward. I'll try to put words like what they need from me. I try to understand from the previous speaker. So I think so. Thank you very much to for the invitation and whatever I can fulfill with the people. I'll try my level best.
thank you so much. Would you like us to
Can you
show your
share the
slides?
yeah slide is not going to talk much, but just go with that.
Yeah.
So what the topic is given is safety diagnostic procedure. Safety in diagnostic procedure. See, safety in diagnostic procedure is important in each and every procedure. When we come across it's maybe the endoscopy, it may be the laparoscopy, it may be the colonoscopy, it may be the bronchoscopy. There are so many scopes we use, arthroscope. But in everything, there is a safety precautions. It's much needed. So, next slide, please. So, next slide. The diagnostic procedure like laparoscopy, colonoscopy, endoscopy, there are so many scopies are there. And dynamic activity that lays on the teamwork. It's not a single man work any other procedure. It's involved uncertainty, unfold over a time, and necessity effectiveness of communication and collaboration among the various clinicians and diagnostic services and the patient and the technicians. Yeah. Next slide. So, what is a diagnostic error? When we get a diagnostic error, the institution of medicine defined diagnostic error in two types. This diagnostic error was already discussed by Dr. Anand. So, I think so. Even though it's important, it's not only in the lab diagnostic error, even it's a clinician diagnostic error. There are so many errors can happen in a clinical practice. So failure to establish an accurate and timely explanation of the patient health problem, or the failure to communicate the explanation to the patient. This is the diagnostic error. What, in my view, next slide, please. So, what is the impact of diagnostic error? Why is important? A misdiagnosis can delay the important treatment. See, it's not a it's not a business. What we are doing as a clinician, it's a treatment means from the what doctors we have an impact on doctors in so many ways. But doctors in their mind, how they work is if they couldn't do a proper treatment, they couldn't do the proper surgery, they cannot sleep. They cannot eat. That is the mind of the doctor. So the important diagnostic error was if I couldn't diagnose one patient in a proper way, I cannot sleep. That will be going on in my mind up to I'm getting a result of the patient. So delay in important treatment is going to delay if the diagnostic error is going to happen or result in an inappropriate treatment. So the disease will be one and we'll be treating in some other way. So ever it's a teamwork. That's why it's from the lab, from the reception, from the like ward boy, everything is important. If the as a doctor, I am not obeying my word of what staff is coming and saying, sir, this patient is behaving in a little bit different ways, sir. So like if I'm not obeying just go like that. If I'm saying I'm doing a mistake, I should find out why he behaved in such a way, for what reason. So he has a psychological problem or he is a stress problem. That so many things which is going to help me in a treatment of the thing. So every listening to each and every one is also important here. So often causing the patient unnecessary physical pain, physiological suffering, and financial hardship because your impact on diagnostic error. Next slide. Next slide, please. So how to yeah provide based approaches. Be consistent in decision making. Think aloud. Commit and confirm, and check in. Talk through your thought process while making a diagnosis. So whenever like the patient is be coming to me, they'll be giving a diagnosis of like I'll be thinking this is the appendicitis. So, but like the thought process is saying no, like if the answer like the patient is giving something like sir, I have the burning maturation, I have the chills and rigor. So I have to think about the other possibilities of the diagnosis also, like maybe it's a ureteric alkaline, maybe it's a cystitis, maybe it's a prostatitis, maybe like some other problem in understanding. So many things we have to think over, and the thought process will make, like so experience will make and give a diagnosis to such a things. One, and commitment and confirm. Commit to the diagnosis and think about what the data support or refutes that diagnosis. So if you diagnose properly, so the patient may come with a clinical diagnosis. I may be clinical, like just simple example I'm saying. If the people like today, around like 15, less than 15 years, kids will be coming to us with abdominal pain. Everyone will have the idea of pain. Idea of pain, vomiting, patient will be having. So like, what's the thought process of normal person will be thinking is idea of pain, vomiting, fever, go for the appendicitis. And if you check for the this one, can also ultrasound or thing like it also shows like my thickening of the appendicitis, maybe chronic appendicitis or there is a recurrent appendicitis. When you know, when you go inside for a diagnostic lab as appendicitis, you won't feel that's a because like even though you do appendectomy and do the send the patient outside, patient will come within a 1 month to you see the same abdominal pain. So what is the reason for that? See here, main reason for the abdominal pain is the mesenteric lymphadenitis. Mesenteric lymphadenitis because the world is changing, the food modules are changing. We are changing from the normal house food, mother food to the industrial food like junk food and other food. Whichever flavor food we are changed, what's happening is like your lymph nodes. That is like whenever you get a ulcer in your leg, you like in your internal region, like, there will be a swelling, right? The same thing,
Yeah.
like I'm just doctor, I'm not explaining for you. It's like explanation for the people other people. The same way, the intestine get an infection or inflammation. That's a like there is a lymph node which is going to swell inside the abdomen. So the allergic process also make this to the kids. Not only kids, like I'm saying, like if I'm seeing in a OP 100 patient with abdominal pain, it's that in that I'm frankly saying 60% due to this reason because of the food problem. So like the commitment before the diagnosis of like appendicitis, I'm just giving you one example. example. Like you have to think over so many things, otherwise you'll be wrongly diagnosing and wrongly doing the procedure, and patient will be going on to the some other hospital. So check in every time you encounter the patient. Continuously reassess the diagnosis made and response to therapy as still appropriate. So I diagnosed like this is a something like this pancreatitis. So like don't stay around there because the patient may have the pancreatitis. Patient will have with the associated with the how the patient have the gastritis. Maybe this patient is alcoholic. He may have the hepatitis. So you cannot stand in on alone like this is the diagnosis which I made. I'm going to treat. So it's need a widespread thinking like a Wi-Fi to come into the conclusion. And like today there is a system is changed. So before like one doctor will be seeing one patient and will decide the things. Today not like that. If I in my hospital there is like in-house people around 15 doctors are there, we will be discussing about like when there is like doubts about the patient, the 15 doctors will sit together and discussing. So each and every thought process will be put forward and we'll be going into the thing. Not only by the doctors, even the nursing staffs are involved here, the duty medical officers, everyone is involved, like their words also taken care here to get into the correct diagnosis. Next slide please. System-based approach. Build no blame culture. Diagnostic error will be happen. Do not blame individuals. That's my uh, thought process. See, I said like even like there was a question like how to diagnose the which is the lab, which is the best hospital. It's a NABH accreditor. It's a good hospital. No, you cannot say that. Like, see, machines can do any error. We are sending from my ISRO, we are sending a racket to the sky. Sometimes it's falling down. It's not like we cannot say our ISRO is doing a mistake. See, it's a error of the machine which is happening. It's not everything by the human art. Like which machine we are buying, we are thinking like we are buying from US, that machine is the best. We are buying from German, that machine is the best. Everything we are buying and keeping. It's the something, some like initial QC or something they'll say, like how to run the machine. If something it's error, the whole result will be changed. So if I'm sending you a thyroid report, the patient on the thyroxine, L-troxin, 200 microgram L-troxin patient is taking. The report is coming to me, patient in hyperthyroidism. That is like TSH is very low and T3, T4 is high. I'm surprised to see this result because like patient don't have any hyperthyroidism feature. Even that result is right, the patient should have the hyperthyroidism feature. The patient is like around 3-4 years he's taking a and like hypothyroidism medicine with me. So I told to do the investigation, send the investigation to some other lab. So patient like my lab staff is coming in asking us like how do we have to pay? No, we have to pay. Yeah, we have to pay. Hospital will pay, but not patient. Yes, I am having a doubt on you. Not the patient have the doubt on you. I am having the doubt on you. Send the thing. I will pay for that. So it's coming like again the result is coming out here again with the error. Let's say enable lab again with the error. So I couldn't come to the conclusion. Again, I'm sending a third thing. A same blood sample. I'm sending to the third lab, the Apollo. So now what to do? See, we are doing a monthly checkup, like that is cost check. Like we have with the Vellore Medical College, we have the recognized center. Even though the lab can do some mistakes, lab like machine can do some mistake, error. But finding out and solving is the best solution. If you are believing that and stopping a medicine and going on to the some other problem, that you are not given a safety to your patient. That is important. So, in same way, like whenever like we are going and doing some procedure, like an endoscopic procedure, if the like we'll be thinking like all the history was taken, like the patient will be taking echosprin and coming inside. Patient will be on echosprin. Emergency patients, when they come with a foreign body in your throat or like in the esophagus, if the staff not ask like patient is like echosprin or my doctor is not asked, or myself is like because of the emergency, I didn't ask the patient. Even I am reason for that. I taken put the patient on the table. If I may taken the foreign body out, but patient will be bleeding. So small things in a safety thing, safety measures like patient is taking echosprin, patient is taking other like antiplatelet medicines, which is most important. Then there are patients like even though like when we are doing an endoscopy itself, there is like when there is a foreign patient swallow the foreign body. See, before that, before going to the procedure, we should know what is the foreign body. If 10 like 5 rupees coin is there, the staff and the team should do the first real like real thing outside. How to bring out this? Which process will bring this out? They have to do the rehearsal before going into the patient. In going inside the patient and searching for the instrument, which instrument will grasp this is a problem. So that is the safety precaution which will take in endoscopic procedure, like a diagnostic procedure or procedure we have to take in a little bit. In a report diagnostic error to prevent the future error, learning from our mistake prevent the future harm. See, I'll be telling like we do the laparoscopic surgery. Today morning I'm posting 2 cases. If the carbon dioxide cylinder shows the this meter shows like it's full, they'll be thinking, the staffs will be thinking it's CO2 is filled. But when we are opening, there won't be a CO2. The error in the meter.
Meter.
So which is not working. So what will happen? Like we given anesthesia, we given the things. I'm not talking about like 5 cylinders, 6 cylinders, like which is patient like you have. Even though you have, you are going to delay the surgery 10 minutes. Like it has to shifted and again you have to connect it to the machine. It's going to take a 5 to 10 minutes by the patient are going to be sit under anesthesia, which cannot be accepted as if I'm thinking my patient is my sister, my daughter, my brother, I cannot accept. Same thing for the patient. If we are thinking in a such same manner, no mistake will happen. Mistake can happen in any hands. Like we are not a god, not doing a mistake, but we do a mistake. But for that, we cannot blame the one person, single person. You did this mistake because of this. I'm like this has happened. This is a collective responsibility we have to take. We have to take, and same time, this error should not happen next time. That is the responsibility of the people. Next slide. So that is a statistic for accurate patient identification. That is a comprehensive patient assessment. Conduct the thorough assessment from the medical patient medical history, current health status, and any relevant diagnostic test to determine eligibility for procedure. See, when we do endoscopy, we tell the patient to do a serological test. That is, you do a HIV, you do a HPCAG, you do a HCV. These all things will spread through your saliva. So we tell the patient to do this investigation that may cost around like I don't think like maybe like in between in 1,000 rupees, nearby 1,000 rupees. So if you are doing a procedure for 2,000 rupees or 3,000 rupees, you are doing an investigation for that like around 1,000 rupees means what patient ask is what's the need for endoscopy? Why you should do a investigation? What investigation this? So you have to answer. How you are going to answer? If you are going to say I'm going to do a HIV, HPCAG and HCV, they'll run away. They'll ask, I don't have this. So explain to them. See, I did an endoscopy for me today morning. If I have HIV, from me that will spread to you. So I have to see the investigation for me first. Then only you won't get the same disease from this. Even though you do a thorough cleaning, thorough like sterilization, the disease can spread over from this. So HPCG, HIV, HCV patient, we never do with the same scope to the other patients. We have the separate scope for these people. That will be like article and done. Only one patient will be done in that instrument. That is the routine. So this is the comprehensive patient assessment when it's coming to the thing. Like in medical history, Like patient will be coming from this like seashore area. Where you are coming from? Like it's more give you a more result for us in my area. Like they'll be most of the people they'll have the HPCG positive. And when the people are coming from like other like places, some other places like the nearby, I don't want to mention the names, like places, they will have the certain disease improper. So medical history is important and health status, like they'll be having echo screen, they'll be having taking some other medicines, like everything is important when you are going for the procedure, diagnostic procedure itself. So review the clinical guidance and protocol. Consult the clinical guidelines, protocols, and best practice recommendation to determine if the patient meet the criteria of the for the procedure. Any procedure, you should have the guidelines for that. How to do any diagnostic procedure or any procedure, you should have the guidelines and protocol. If this procedure I'm going to do, these are the things should be ready before the procedure, before the clinical diagnosis. That's going to keep your adrenal secretion less. Same time, your other people stress also is going to reduce, and the patient will get a benefit. Multidisciplinary collaboration. That is, collaborate with the multidisciplinary team, including the physician, surgeon, specialist, and allied health professional, to assess the patient eligibility comprehensively. This is what I was talking from in like starting. Next slide. So, risk assessment and stratification. Conduct the risk assessment to evaluate the potential risk and benefit of the procedure for the individual patient. Simple thing like when we are diagnosing something, like I'll come in the endoscopy itself. Like we are just putting a endoscopy. There is a risk. What are the risks are there? Like if the patient is like we are thinking like patient is anemic. When we are going inside, there will be a patient will be having a web formation in the trichopharynx, near the trichopharynx. So you cannot enter inside. Why this is coming? It's reason for the reason is anemia. So when anemia is there, you should think this is because of the anemia. There is a Palmer-Vinson syndrome. That is, you can have the web in the esophagus. If you are prepared for that, you can negotiate that. Preparing for that, like you will be having the guide wire to go across that, go to dilate that, and everything will be having a so risk assessment from the history, from the clinical assessment, everything. The assessment, this may patient may have this risk. So if the patient is coming with the dysphagia, like can't swallow anything, like you have to think patient may have the growth in the lower esophagus, or like each and everything, like the clinical assessment, the risk assessment is important in each and every patient. Then consent. Today is like informed consent is everything is like most important. One day I was asked, I was doing a surgeries, like mostly like per day, 3 to 4 laparoscopic surgeries will be minimum will be doing. So like I was doing cases that day, somewhere 8 cases there. One case came from outside. They did a surgery. Morning, next day morning, like patient was getting up and eating everything and so happy. And they told like super sir. And the wife was saying, sir, only one problem, sir. I was stunned. What happened? She was saying, sir, the concern. Tell me. Sir, they returned and asked me, taking some consent. What was the consent? She was saying, going on saying the consent, everything. Then, she was saying, unwanted things can happen in anesthesia. She was so worried, and even I signed her, how can you ask like this? We are believing on you and coming. And I told Seema, I'm not a god. The anesthesia as per se can like we have 1% of risk in general anesthesia these are the things can happen before 20 years or 50 years we'll say we'll take care come we everybody was thinking the people were thinking treating a doctor as a god so something happened also they won't worry yeah doctor tried their level best and something happened but not today not today by the people. So everything needed, every person should be taught about their disease process, their risk factors, their outcome, and the complication which is going to come. Everything should be, even it's a diagnostic process, we have to explain to the people who is coming as a patient to us. Next please. Next slide, please.
So can we close
Yeah,
in the
please.
next
Yeah.
couple of minutes?
So
Yes.
no problem. No problem. Okay.
No, sir, in
So
the next
ensuring
couple of
patient.
minutes. Yeah,
Okay, ma'am. So ensuring
go ahead.
patient safety, completing procedure without harm, high-risk patient in identification, customize the care plan, and procedure adaptation, and post-procedure care and follow, and patient family engagement. These are the most important things. Next slide. These are the facilities, effective communication of finding, clear and conscious documentation practice, interdisciplinary collaboration, utilization of health information technology, and patient-centered communication, timely reporting protocol, documentation and record keeping, feedback mechanism, awareness generation and training. Next slide. So maintaining, next slide. So already this was talked about the things, allergies and other things. So thank you very much. Any
Thank
question?
you.
I'm ready
Thank
to
you.
answer. I think
Thank
so. Maybe which I talked, it may be useful to the people.
thank you, sir. Thank you so much. Over to you, Keshav.
Thank you so much, Dr. T. Shivakumar. This is a very great, valuable, informational slide, actually. So let's move to the next speaker as we are left so much less time. So I would like to invite Mr. Kabir Mahajan. He will be speaking upon safety in radiological and radio imaging department. So can we have the slide, please? Over to you, Mr. Kabir. Thank you.
Thank you so much, Keshav. Thank you, Ratna ma'am, for having me. Just a request, Keshav, can I present the slides on my own?
Yeah, sure.
Okay,
Vikas,
I'll
can
just share
you
my.
make it access to Mr. Kabir?
Please go ahead. We will stop sharing.
Can you see the screen?
Yeah.
Yes, we can.
Perfect, perfect. So it's such a pleasure to speak after stalwarts Dr. Shiva Kumar and Anand sir, who's the leader in diagnostics. Radiology, of course, is somewhat different from lab medicine because the patient has to actually physically visit the facility. And so I'll be taking you on some of the points that we follow at Mahajan Imaging and Labs. So essentially, we broke down this lecture into the following key points, which are essential for patient safety in a radiology setting. Uh, First is everything revolves around the patient. So starting with the way we interact with the patient and how we communicate all the information, whether it's on our contact center or if the patient, when they physically visit us, it starts from that. Then we move on to patient identification, patient privacy. Uh, Anand sir and Siva Kumar sir also spoke very in detail about that. Then we move on to why the investigation is necessary, justifying the investigation in radiology, especially with X-ray based modalities such as X-ray, PET-CT, CT scan. It is even more important, and of course, it's very important, especially in our society where there are unfortunately many citizens of our country who cannot afford. So it's very important to justify the justification. And then, of course, is the most important part upon the reporting, and then moving on to the infrastructural safety, radiation safety, and MRI safety. So at Mahajan Imaging and Labs, we believe we are pioneers in patient-centric radiology and diagnostic. And this was a lecture that our founder, Dr. Ash Mahajan, had presented at one of the largest radiology conferences, which revolved around patient centricity. And this is the practice that we follow, right from a seamless appointment system, personalized service, ambience, interaction with our radiologist, the experience of actually undergoing the scan, and then once the test is done, ensuring a post-test discussion with our doctors and a quick turnaround time, and also interaction with our referring physician. And this is great because it leads to a net promoter score of 95% across our network. And this is something we really follow in detail. So once the patient is interacting with us, it is our duty to clear all of their doubts in the best possible manner that we can. Whether it's prerequisites of the tests, so such as fasting for any contrast, or in some procedure, in some tests, you have to stop certain medication. Uh, we have to be very accurate about that information. Uh, Moving on to cost breakup of the test, this is very important. The waiting time, when the report will be delivered, discussion with our technologist about history, uh, and of course, discussion with our radiologist about the report that is done. And also, we strive for interaction with the referring doctor for any urgent or critical finding, and especially for complicated cases we do a lot of interaction with us. So there is interaction with the patient and the stakeholders of the patient at all levels. Patient identification is very important. Uh, at the time of registration at the front office, we send out an automatic WhatsApp message to the patient with their age and gender. And this ensures that if there are any registration errors by our front office team, the patient can point it out there and then to us. So that saves a lot of hassle uh, later on. Then, when the patient is being prepared for the radiology test, our general duty attendant confirms the test. Then they help the patient get ready. Then once the patient moves on into the equipment room, our technologist, before carrying out the investigation, verifies the unique identifier, a unique identification number. They also put in a note on any clinical history or any indication. And all of this is done, yes, to get the clinical history, but also to ensure that we have the correct patient, we have the correct organ that is to be examined, and ensuring that the right procedure is done. So in radiology, it's very complicated at times, especially when it's a busy center, because an X-ray might be required of the right knee, but in all the hurry, you might scan the left knee, and so you have to be very precise in what you're scanning. All of this is important for traceability and identification. Later on, once the report goes out, we have all the details mentioned on the images and the report. Then the radiologist, which is why the patient is coming to us. They are coming to us for a proper report. So the radiologist would refer to the clinical history mentioned on the consent form while making the report, and also will look at the previous records of the patient or the previous clinical history, which are also attached and available to the radiologist to make the report. So this on the right is an example of how we send out an automated message at the time of registration. Then finally, once the test is over, at the reception counter during the dispatch of the report, now there are two ways in which we send out the report. First is actually the written report is sent out as a WhatsApp message. But in radiology, we are generating images. So all patients have to visit our facility to actually pick up the physical reports. Therefore, we have to ensure that the correct report is given out for the correct patient. This is very important because you cannot have someone else's report go out to someone who doesn't even know the patient. So, therefore, we do that with the payment receipt or the photo or the screenshot of the forwarded message sent on the mobile number during the registration. And we also have a barcode, etc., where the patient can access their report, the physical, the actually the written report. So this is how we ensure that the correct report is given to the correct patient. Then patient privacy, I will not go into too much detail because Anand sir and Sivakumar sir have already touched upon that, but it is of utmost importance, and we are very happy to know that this is getting more and more uh, uh, prominence in today's day and age. So in our group, actually, the patient registration software uh, is very much controlled and has multiple layers of security, so that no patient information is leaked out or is sent out to someone who doesn't actually require it. So all of the users of our software have a assigned username and password controlled to enter into the system, and it is all controlled by our head of operations at each level. So they control actually who gets access to what. Then again, patient history is only taken by the technologist or the radiologist in the console, so that no information is leaked out. Then we have physical infrastructure such as curtains and locks to ensure that the patient privacy is maintained even during the scan. Very relevant for female patients undergoing a mammography scan or an MRI of the MRI of the breast. It's very important during that time. Then justification of investigation is very important because we might be exposing the patient to a certain amount of radiation if it's a X-ray based test, or in our case, many patients cannot afford a test, so it is very important for us to justify. So all prescriptions are verified, uh, and if the by our doctors, so as to understand that there is no wrong investigation done. The radiologist and technologist take the relevant history. And in many cases, in case our radiologist feels that this modality that the doctor has referred for is not the most suitable, we will actually change the modality in consultation with the referring doctor. And this happens quite a lot in our scenario, where a patient might be referred for a PET CT, which is a fairly expensive modality, but actually our doctors realize that you don't need a PET CT and you need perhaps a regular CT scan, which is probably one third of the price. So this really has not only a clinical impact, but this actually provides a lot of trust uh, in the eyes of the patient. And at all stage, the patient and their referring doctor are informed uh, of this situation. Secondly, the next is the most important part, which is for reporting and image acquisition. Annual assessments are done to ensure compliance with our established protocols and standards. This is something we take very seriously, especially with NABH guidelines as well. We have cleared more than 50 audits in the last few years without any major non-conformities. So we are very proud of that. Peer review sessions are regularly held for our radiologists to understand the process of interpretation, image acquisition, and analysis. We hold regular trainings for our technologists to reduce error rates during image acquisition. We use standardized terminology across our network for the reporting, and this ensures reduction in errors as well. There is a feedback mechanism, so we really interact with our referring doctors to get feedback about what happened with the patient, and this can be both positive, and we really value constructive critical feedback about our reports as well. And we are continuously monitoring all performance metrics for various quality indicators such as turnaround times, such as accuracy of reports, and this helps in identifying areas of improvement. So we regularly undergo such audits by third-party providers who actually compare our reports with theirs. As I said, for patient-centric radiology, we've pioneered the experience, and because the patient has to come to us, the ambience of our facilities is very important. This is one of our centers located in Gurgaon, so this is actually what the waiting room looks like. So we put in a lot of effort to ensure that the ambience is nice and colorful, because no one is happy to come to our facilities. Then this is what our MRI room looks like. Again, nice and colorful. When you've been prescribed an MRI, you're very anxious, you're in pain. So whatever we can do to reduce that anxiety is really beneficial for the patient. So this is how all of our MRI rooms actually in our network look like. This is how our PET CT looks like. So we have put in a lot of effort in ensuring comfortable scanning experience for the patients who are very anxious. Infrastructural safety is of utmost importance because we have hundreds of patients visiting our facilities. So we have, as I showed, a non-intimidating, colorful environment. We have approachable locations with appropriate parking facilities, and we provide valet services, patient-friendly environment, and cleanliness. I think hygiene is very important for us, and we have structured programs even for our housekeeping staff to ensure that all norms are met. Then we provide facilities for recreation, coffee and tea, and enough space for waiting and for all modalities. Then we do have all, changing rooms and washrooms are fitted with grab bars and emergency bells because patients are sick when they come to us. We have dedicated wheelchair bays and stretcher bays. Hygiene is maintained, and we strive for training at every step while handling the patient. So these are some videos. Uh, we actually take this very, very seriously. So we can see how training is performed for patients undergoing an MRI on a wheelchair, and for patients how they are carried out in case of certain emergencies. Uh, then medical emergencies management is again very important in our setup. Uh, you would you would know that there is some amount of theoretical chance of a reaction when a patient is injected with a contrast. Therefore, across our network, we have a full-time anesthetist who is present in the center to provide sedation and for contrast CT. So this is a theoretical chance, but there is a chance of a patient developing either a minor or a very severe allergic reaction. So we are prepared for that as well. There are regular training sessions again on patient emergencies, and I'll quickly play the videos while I speak. All technicians are trained on BLS, and our trainings are provided by our cardiologists and anesthetists. We have a crash cart that is maintained and available to handle any medical emergency, and no contrast studies, whether MRI or CT, are done in absence of a radiologist. So while this results in definitely loss of revenue, uh, especially post 5 p.m. when we don't have a doctor, but we are very particular about this. So these are some of the best practices that we follow for medical emergencies, because again, we get all kinds of patients. Some might be very sick. Therefore, we have to be very particular on this aspect. Fire safety, again, I will not go into too much detail, but we take this also very, very seriously. We have, in fact, more than appropriate number of fire extinguishers and sprinklers, smoke detectors. In fact, in one of the hospitals fairly recently, there was a small incident where we detected some fire, and we were actually able to contain it very fast in support with the support of the hospital authorities. So these trainings are not just to have a tick mark on the NABH guidelines, but we actually follow them very seriously, and over the years we've seen huge benefits of that. Then MRI safety, again, very important, because MRI works with magnetic waves. Therefore, you cannot take any metal or any product with metal inside the MRI machine. That would be very, very dangerous. So we have to be very careful about what goes in the MRI machine. So we have warning notices. We have all patients are screened for presence of ferromagnetic objects before entry into an MRI scanner. So this is irrespective, even if it's the president of India, we have to scan them for such objects before they enter into an MRI scanner. And there have been some incidents reported from various parts of the world where there was a VIP who was being scanned, but their security officers actually went inside with a gun that then flew off, and there was a very bad incident that happened in Brazil. So we have to be very careful. Uh, the patients and attendants have a safety checklist that they have to fill in, and only MR compatible objects and wheelchair stretchers are allowed inside the MRI room. And regularly we are doing trainings as you just saw. Then I mentioned about the use of X-ray based technologies such as X-ray, DEXA scan, PET CT, CT scan. So radiation safety is again very important. Uh, so we have across the network, we have radiation rooms which have red indicator lights when the radiation source is on. That means if an X-ray is going on, there will be a red light outside that room so that no one, even by mistake, enters the room. We have appropriate signage. We have plenty of lead aprons, gonadal shields, thyroid shields, pediatric shields, so that radiation exposure is not given on parts that are not being scanned. Then, what is very important is that we follow the principle of ALARA, which means as low as reasonably possible for radiation purposes. So, this is a principle where if you give more radiation to a patient, you will generate much better image quality. And therefore, the radiologist will be able to report it more faster, very accurately, because they can see everything very nicely. But we follow the principle where we want to generate only diagnostic quality images, thereby reducing the amount of radiation that the patient is exposed to. And all of our equipment have AI based technologies or some traditional technologies which reduce the amount of radiation. We are particularly careful with radiation to female patients, especially with pregnancy or childbearing age. And also, we are very careful with pediatric population during any X-ray procedure. Our technologists have TLD badges, which is actually measuring the radiation output, and radioactive materials are also handled very carefully uh, and only in the designated area work. And again, we stress a lot on the training. So this is again a snapshot of a training session that is being done for radiation purposes. So these would be some of the key uh, practices that we follow at our group, and we would expect uh, all, if most, if not all, radiology centers to practice. Thank you.
Thank you so much,
Thank
Mr.
you.
Kabir. Thank
Thank you.
Yeah.
Thank you, Mr. Mahajan. That was very comprehensive. In fact, much of it wasn't known to me as well, even though I'm a trained physician. And therefore, common man really doesn't know much about this area. And there needs to be a lot in terms of making them aware. Just one very quick question, and this has got nothing to do with the diagnostic safety per se, but perception of patients around these medical imaging machines. They are very big and scary, and the media and especially the movie industry has shown them as something that the patients are afraid of. So very often we hear patients saying, "This has been prescribed, but I'd rather die than go inside that machine." What can be done to allay those fears and make people more confident about these imaging techniques? Because I think that's an extremely important area that needs work.
Thank you, ma'am. And this is a very relevant question. And one feels for the patients. These machines are fairly bulky, and you know, it is obviously not nice to get inside a machine. There is no doubt about that. What can be done is that, again, like I showed you some of the images of our scan rooms. We try to make them colorful so that the patient at least is put at somewhat ease. The other is the right kind of education has to be given to the patients. If given a choice, none of us would want to go to any healthcare facility, not just medical imaging, except of course
Yes.
if it's pregnancy or if it's for preventive health. If given an option, we would not like to visit, but unfortunately, one is required, and the right kind of education has to be given. Always there is a sort of a cost benefit analysis that needs to be done. While a patient would, I, it's not good that a patient would rather die rather than get an MRI machine, because millions of people are being scanned every day. Yes, it might not be a extremely pleasant experience, but there are ways and means of getting it done. In fact, claustrophobia is very common with MRI patients, and many patients realize of that only when they come inside an MRI machine. So again, small things like having a duty attendant just hold the hand of a patient when they are undergoing a scanner, that we've seen, that just simple step really shows tremendous benefits. And at the end of the day, our client is the referring doctor. If they are not able to get the diagnosis, then he or she will question us. So and it is in the best interest of the patient. So these are some of the practices, but I agree, right kind of education has to be given to patients, and machines are becoming faster. They are becoming with less noise, and they are, all companies are striving for patient comfort. So that at least is good news on that front.
Thank thank you. Thank you. I think a little more awareness around what these machines are for and that they do not cause any harm and that they are for accurate diagnosis would go a long way in building that confidence. So thank you so much. That was a fantastic presentation. And I wish all centers were as beautiful as the ones that you showed us today. Unfortunately, that's not the truth because I've been to centers that are really scary and there is no waiting space. And sometimes you have to hold your bladder so that you are able to go there and it's not a very comfortable feeling. The other personal experience that I have is once you are in the machine, it makes a lot of noises. And if you are not warned in advance, it is quite alarming. You're also asked to hold your breath for a very long time sometimes. And if somebody is not talking to you throughout that process, then it can be a very, very scary experience. And I've seen this in very educated people who just don't want to go inside that machine. So desensitization and helping people understand that this is for their best interest would possibly work for the benefit of everyone. So thank you once again, and over
Absolutely.
to you.
Thank you, Mr. Kabir. So as we're running out of time, so we just move quickly to Dr. Anu. Welcome you, ma'am. Dr. Anu is a training lead at Find DX. So over to you, ma'am.
Hi, thanks, Pair, for inviting me and having me here. And thank you, everyone, for staying put and not leaving. I know it's late, uh, uh, but this is the last topic for today, as I understand. And then there is now a shift in gear right now. So far, we've been hearing all corporate sectors. I come from the public health predominant domain. Our teaching is for the public health, and so a lot of what you said is sort of uh, very interesting, impressive, but not really very possible in the public health sector. So let's kind of shift gears right now, and especially since one of the things which Dr. Anand has said in the beginning about the trust deficit, in a lot of the clients in the public health sector may not even know that there is a thing called trust deficit. They just trust whatever you give them is the report. So there is no questions asked. So I think the onus of that diagram that you showed, from pathological nonchalance to getting to that predictive area of your competence, is the onus is entirely upon the healthcare provider to be aware of everything and provide it for your patients. And having said that, one disclaimer: in the vertical programs like TB program and HIV program, there is a lot of quality assurance across the level. So that is done. So we'll give you a couple of examples of that as we go along. And second thing which I wanted to say, I really didn't know what the target audience is going to be. So I have made a presentation which may be relevant to some and not relevant to others, or vice versa. So we'll just get started with that. So I hope all of you know what POCT, or point of care testing, means. Point of care testing is that kind of testing where you take the test to the patient. The patient doesn't come to the lab. So if your patient is in a ward, that can happen in a ward. A patient coming to the OPD can have that. So there are multiple mechanisms by which point of care testing is done. So there are pros and there are cons. We'll discuss in brief. There are 30 slides. Don't get alarmed. I'm not going to go through all of the slides. I will just breeze through them. Next slide, please. So this is the write-up that the organizers had sent me. So there is a growth rate of, if you can just 12 to 15% annually in point of care, means that the focus of testing is shifting from a central laboratory system to a point of care testing across the world. So now it is important to assure the safety of your results. So there are 4 mechanisms which the organizers have indicated, which I will sort of briefly go through. First one is having validated and certified operators. So what is that? Because we'll come to that when we come to the specific slides. And then expert specifications for security and performance. So if for people who are not laboratorians, let me just tell you 2 things. Validation is a process by which a device or a testing device is finally the performance qualifications are done by the provider, by the manufacturer. You get your equipment validated by FDA, organizations like FDA or CE, or in India, BIS is the Bureau of Indian Standards. So many of these equipments are certified or validated or by these operators. So that is a very important thing while you're purchasing it. And second is something called performance qualifications. So you need to know whether an equipment or a device that you're using is fit for the purpose for which you are using that. So that is important. This is all to assure the safety of the results. And most importantly, you have to follow the directions given by the manufacturer. The training is very, very important for the operators. And it's not enough to have just the device given to somebody to do as whatever they want with it, but there should be stringent quality assurance. And finally, there should be safeguards, which is quality assurance. Move on to the next slide, please. So point of care, this is just, we can skip it. It's also known as bedside test, near patient test, physician's office, extra laboratory. There are many terms that may be used to indicate that it's a point of care testing. Next one. Next slide, please. So I have red boxed the weak points. There are a lot of strong points. There is quick, rapid testing. The time is really reduced. And especially in a country like India, where all the rural settings cannot have big standalone centralized laboratories, point of care testing is an extremely handy tool. But you have to be aware of the weak points when we are, sorry. Can you go back to that slide? No, next. Yeah, the red box, within the red box, you can just look at that. So the weak points are you cannot handle high number of specimens, which is beyond the scope of today's discussion. What we are focusing on accuracy and precisions are adequate only for screening. That should be a point that everyone should be aware of. Most of these tests will only give a screening. That is a preliminary report. If you want a better report, you have to have confirmatory mechanisms. It's not applicable across the board, but in a lot of POCT equipment or devices, it will only be enable screening. Second is limited test level. That again is not applicable for us, and difficult QC management, quality system management is very difficult. And there is LIS connectivity, as you know, the reporting is always manual and it's not connected to any lab information system. So these are the significant drawbacks where patient safety is concerned. Next slide, please. This is an indicative picture. So the upper row is about the central lab testing, and the lower row is about a POCT testing. And the green arrow here shows the time saved by POCT, because you directly take the sample and you analyze it and you give the result to the patient immediately. There is a lot of time saved. That is one of the biggest advantages of POCTs. But as I said, in India, where central labs are not probably available in the rural areas, it's a great advantage to have these devices to give some kind of a report. Next one. Next slide, please. So this is again advantages. I'll skip it. Next one. Next slide, please. Okay, there are classifications. There are multiple types of technology and on basis of different analytical principles. And there are single use, qualitative means yes or no. Is it positive, negative answers are there? I'm looking at the first column here. And the second one is single use, quantitative. You give actually a number using a cartridge and all that. We'll come to the examples. And there are multiple use cartridge systems, which are like benchtop. There are multiple types of technology for POCTs. So depending upon the principles, we'll see a few in the next few slides. These are assuming you are, most of you would have seen the picture on the right side, which is a multi-sticks for urine. These are testing strips, POCT. You just dip the strip in the urine and read it across the color spectrum to see whether there is glucose or there is albumin. This is a very commonly used point of care testing. The second kind in the lower side is a urine strip. All of you would have seen urine pregnancy test strips, which are called the lateral flow assays. You put this a drop of urine or whatever you want to test, and then you wait for the development of this control line and a test line. So it's a very commonly used kind of testing in a lot of infectious disease parameters. You do that. All of you would have heard about HIV testing, hepatitis B testing, HCV testing. All those testings are done through lateral flow assays. Next one, please. Next slide, please. So these are a little more complex systems, but they are also POCTs. And one of the examples I am giving you is a CD4 analyzer, which is very commonly used in India. This CD4 is a parameter which you assess a prognosis of treatment in HIV. So CD4 count goes up as your treatment is effective. So they have this POCT equipment across the program, national program now, so which gives a quite a reliable count of the CD4 to the patient. So this is based upon antigen antibody reactions. These small machines, very, very small, very handy machines, and these are there. But the program has taken effort to error proof it as much as possible. That's what we'll come to in a little bit. Next slide, please. This is for molecular, even in molecular, like antigen. So we talked about different kinds. We talked about strips. We talked about antigen antibody reactions. Now we're talking about molecular. All of you would have heard during the COVID time about TrueNATs, which were launched across India. The molecular testing for COVID positivity, COVID-19. So this is NAT testing is very prevalent now, used in the TB program for diagnosis of Mycobacterium tuberculosis. You can do other pathogens also. I'm just saying there is one program which is using it across India in all the NAT labs for Mycobacterium tuberculosis detection. It also gives about sensitivities to rifampicin, also is given by this small machine, and it's also POCT machine. Next one. So interferences we already heard in the first presentation by Dr. Anand. There are the same is applicable here also, pre-analytical, analytical, and post-analytical. So since this particularly POCTs are a little more vulnerable because you can just transport it around. So you need to be very aware of the storage of reagents, tests, samples and all, and you shouldn't expose it to any condition which will deteriorate and degrade your analytical system, because analytical systems comprise of reagents, tests, people who are doing the tests, the environment, the equipment, everything comprehensively, we call it an analytical system. But in this case, this entire analytical system can be replaced, but taken from one place to another. So it becomes more vulnerable to adverse effects. So that should be understood. So like similarly, humidity, temperature are all not controlled. A lot of these machines don't require much of climate control, but regardless of that, some kind of cognizance should be given to controlling the environment. And next slide, please. And pre-analytical factors, we already said. Patient identification, we have already discussed these things thoroughly: collection, handling, processing. Then also hemolysis clotting, underfilling and overfilling, which is a very important part in this kind of analysis systems, analytical systems, because they have small capillary tubes. If you fill it too much, like CD4, overfilling will give you a higher result, underfilling will give you a lower result. So these things are part of the training that the technician should undergo before they are asked to operate the system. Next one, please. So again, hemolysis, bigger machines will flag hemolysis, icterosis jaundice here, you have the presence of bilirubin. Lipemia is a presence of fat in your plasma or serum or whatever. But in the case of smaller machines, this may not happen. So you may finally end up giving inaccurate and incalculable results. So that the operator should be aware of that. And faulty procedure, of course, not following the SOP, all these things will lead to erroneous results. Come down. Next one, please. Okay, so these are the ideal prerequisites. This is just given, what is the time of your analysis? Is it portable? If it's a single step, is it multiple thoughts should be invested while you are thinking of getting a POCT device. I'm just leaving it here because this is a little too much for that scope of discussion now. Come down little, next one. And also, whenever whoever is getting a POCT, you have to do a need assessment. It's very important. Is it really required? Is it going to really help the system? So a need assessment, there are multiple questions that you can ask. Again, I'm leaving it here because it's too much of information for this one. So I'm moving on. But anybody, if you're just passing on the PPTs to people, then maybe they can look at it. Next one, please. After this, we are coming to the core of this concept of this discussion is how do you minimize errors and afford safety to the patients. Next one, please. So now the good thing is that this is ISO 15189. I don't know whether all of you know about it. Right now, we heard a couple of people talking about NABL accreditation and all that. So there is an international standard for operation of labs. It covers from pre-analytical or even before that, pre-analytical to pre-analytical to examination to post-examination to everything. How to do each activity in the lab. Earlier, this standard did not include POCTs, but in the current edition, which came out in 2022, POCT has also been included. Earlier, it was a different standard, 22870. And people who were operating labs didn't really need to bother about POCTs if they didn't want to. But now they have brought it under the ambit of 15189, and the other standard has been withdrawn. So that now whenever somebody is applying for accreditation, this also will be part of it. And it is recommended. And this is a voluntary process. Any accreditation is a voluntary process, but labs are encouraged to bring in their POCT devices also into the ambit of accreditation. Next one, please. So there are specific criteria which have been indicated here. One of the clauses that the standard talks about is acceptance. When the equipment comes in, there are a lot of procedures. Even you're talking about larger equipment, lab-based equipment. When they come in, you do a lot of processes to verify it before you place it into service. So similarly, now this is also mandated for point of care set equipment. It's not like you just take it and start using it. So if you are getting accredited, you will have to take care of your POC equipment also. Next one. So some test, which is just, I am suggesting, it's not from any reference. For if there are laboratorians here, you may understand, you can do a precision check, you can do accuracy check, and you can do a linearity check. Again, since I don't know the composition of the audience, I will not go into the details of it. Precision tells you about repeatability. If you do a sample 20 times, how close the values will fall. And that is expressed as percentage of coefficient of variation. So that can be very easily done. Accuracy is something we can very easily do with compare 20 samples across the analytical measurement range with the new equipment, with the main analytical equipment. Aapke lab mein equipment, if you have one already, which is a standardized equipment, or even another standardized POCT, please compare with that and maintain that your results are comparable. Establish comparability. There is something called Bland-Altman plotting. I'm not going into that. Again, verify the linearity range. Suppose a equipment manufacturer is claiming, like a glucometer is a very commonly used equipment. Say if the equipment manufacturer is saying I can measure from 40 to 500, please verify that. So that is called linearity verification. So these are a few acceptance testings that you can do for any of your, these are equipments giving numerical values. Next one, please. Next slide. So again, harmonization is an ongoing process. Do this comparison once in 6 months at least to see whether your POCTs are comparing with the main analytical equipment. Because in every, if you, in a 100-bedded hospital, you will have at least 10 glucometers, and all of them may be giving different values. So there is some kind of comparability should be established at least once in 6 months, and this is part of your stipulation of the standard. And for those tests which are giving screening tests, which is giving yes, no answer for hepatitis B antigen, for instance, please establish comparability with confirmatory tests. If you also have an ELISA system in the lab, please compare and say that my thing is positive in my card, it's also positive in ELISA, or vice versa. So this kind of comparison should be established to error-proof your POCT systems instead of blindly reporting on the POC systems. Next slide, please. So again, ISO is coming to some more requirements. This one I'll skip because it's a lot of language there. I'll come to the next one. Next one, please. So this is something ISO is giving the labs organization, the governance, the ultimate responsibility. The governing body of the organization shall be responsible. It's not anybody's baby. If you have POCTs in your institution, it is the responsibility of the governing body. And there should be respective responsibilities and authorities specified and communicated. And there is also clinicians also should agree that these are valid POCTs that you are purchasing for your lab. So that also is something that you need to do. And it may be managed by a health professional grouping. So this is ISO's language. I have just copy pasted it from the ISO standard. Next one. So that is A.2. A.3 says quality assurance program. Quality management system should be there around every POCT test. And also training program should be available. So these are all mandates of the ISO. Next slide, please. I'm not going into the details. I'm just giving you a couple of examples from national programs like NACO. NACO uses a lot of rapid card tests for their diagnosis in their ICTCs, but it's not like up to anybody to decide it. They have an excellent quality control program for internal quality control and for proficiency testing. IQC means internal quality control proficiency. That's a 3-layered controlling mechanism that NACO has indicated. For people who are interested, you may want to read about these things. I'm not going into the details, but there is also proficiency. There are 2 kinds of quality assurance. One is internally, which you do on a daily basis or a periodic basis, and proficiency testing, which is when you're getting blinded samples from somewhere and you need to give that result. So the panels are sent by NARI, which is National AIDS Research Institution. And also there is reverse testing. In some percentage of positive and negative samples are checked by state reference plan. So there is a very robust mechanism of quality assurance in the POCTs, which are used by the national program NACO. Next one. Similarly, for CD4 testing also, there are internal quality control program and proficiency testing program, which is run by NARI Pune. So this is a error proofing mechanism that this is kind of mechanism should be available for all POCTs. These are just examples. Next one. This is for the NTEP, National Tuberculosis Eradication Program. They have got NAT. I showed you the picture of TrueNAT. For the TrueNAT, there is a full guideline, practical guide for implementation of TrueNAT. As on the left, on your right side, you see that box. So the program has come out with guidelines on how to use the thing qualitatively. So there is an entire quality management system around TrueNAT, which is defined with all these different components, competency assessment, internal controls, external controls, on-site supervision. Whatever is required to error proof it has been done by the program. Next one. So again, NACO, back to NACO, there is also kit quality assurance. There are consortiums. Before NACO sends out kits to the field, they have consortiums which will validate the sensitivity and specificity of the kits which are stated by the manufacturers. They are done by the program itself before the kits are given to the field. Next one. Next slide. So now we'll come to the last two slides. So what can the facilities do? Now we have talked about what the program is doing, but now some facility is now planning on buying whatever POCT. So whatever you need to do, first thing is purchase consideration. Very, very important. You need to have some considerations when you are buying it. Choose products which are validated or certified. Some of the bodies which give these validation are FDA, from the US, CE from the Europeans, Europe, and BIS, India, Bureau of Indian Standards. You just look for validation, whether these equipment are validated or devices are validated. And again, one more layer of ensuring that is look for in-country validation and approval. So there are kit consortiums for different kits, whether it has been validated by the consortiums or DCGI is the drug controller of India. The approvals, these approvals, there are databases are available on their respective sites, and see whether these are approved before you make that purchase. Understand the performance specification. This is very important. All manufacturers will give you on your kit insert or your operator's manual or whatever the document that they are giving you, get it upfront. Even before you place a purchase order, you get it upfront and look at what is the coefficient of variation, CVs, the performance specifications that I talked to you about earlier. What is a comparability? What is the accuracy? What is a linearity? You have to, and what is a sensitivity, specificity? There are multiple ways in which they will state their performance specifications, and please be aware of that. This is a huge topic, something that people should understand, because every equipment comes with these certain claims, and then you have to compare it with the performance requirements. So there is something, what is acceptable to you, something which you should know. And finally, there's this concept called fitness of purpose. Is it fit for the purpose for which you're buying that equipment? That needs to be ascertained before you actually make that purchase. So this is a big topic. You can go into Westgard site, if whoever is interested can look for more of this and understand the details of these different specifications, and also two concepts: performance specifications, performance requirements. What do they specify? What are your requirements? Are they matching? If they are matching, it's fit for purpose, go ahead and buy it. If not, look for another alternative. So this is something that you need to look for. Next one. Next slide, please. So finally, there's develop a quality management system around every point of care test. Don't just leave the thing for the technician to do whatever they want with it. You have to develop maintenance protocols, training protocols, and quality control protocols for periodic precision checking and comparability checking, verification of batches, new batches or lot verification, confirmation for screening only tests, and if possible, enroll in proficiency testing wherever available. It may not be available for glucometers and all that, but it's available for a lot of POCT tests. So please enroll and provide optimum accommodation and environment, and provide the storage of kit as per the manufacturer's instruction, and use the right sample, which is very important, because in many of the lateral flow assay, whole blood is not validated, but I have seen it being used for whole blood when it is only validated for serum and plasma. So use the right sample, which is important, and also indicate on your report the screening nature and the limitations of the test. These are a few suggestions that I am just saying from my side. It's not like a referred immediately, but from my lab experience, these will be what I will do for a POCT test. Where if I'm going to start a certain thing, at purchase, I'll do certain things. And once it comes in, I'll develop a quality management system around every POCT test. So these are thoughts I'm parking with you for further analysis and improvement. Thank you. I think that's it. Thank you.
Thank you, Dr. George. That was really comprehensive. And thank you so much for throwing light on several of those aspects which we normally do not hear in most of our conferences. I mean, technical conferences is different, but general public health conferences, some of these aspects are certainly not discussed, and this was very useful and very informative. So thank you so much, and
Thank you so much.
over to Keshav to give his
So
conclusion.
thank you to all speakers for sharing their valuable insights. We are covering a wide range of topic related to diagnostic safety, from importance to accurate patient identification to effective communication of findings. So before we conclude, I would like to remind everyone to mark their calendar for our next webinar. Details will share you via email or our social media channels. So the title will be Multi-Stakeholder Perspective in Diagnostic Safety. Once again, thank you so much. Ma'am, the last words from you, if you want to add.
No, no last words. Thank you so much. It's a evolving journey where everyone is learning from each other, and we are very grateful to our speakers who have given us time today. So thank you. Thank you so much. The recorded sessions will be available in a couple of weeks, and those of you who have missed out on any aspect can go back and listen to the recorded session. So thank you again.
Thanks. Thanks a lot.
Thank you so
Thank you.
much.
Thank you.